South Carolina, and felt, as did I think a lot of people on this call, that there was something missing from the care she was providing, and went and did a palliative medicine fellowship at San Diego, which is really one of the outstanding programs in palliative medicine. And then I was fortunate enough to recruit her to Colorado. And although it wasn't my intention, I couldn't think of anyone better to take over the program when I left to come here. And she's been doing an outstanding job and is working with me on a new PCORI grant, and will be working with me on other grants, and has really been a leader to a lot of people in the field. As I've shared with people, my approach to pain and the way I teach pain comes from Christina. So I'm glad that she was willing to give this lecture for us today. So I'll turn it over to you, Christina.
Thanks so much, Benzie. That's really kind. Yeah, just a shout out to Rochester. I'm from Buffalo. U of R is my alma mater. I graduated in '97 from Rochester. So coming up on 25 years. And yeah, I owe a lot of the foundation of my career to the U of R and my time there. So really a treat to be with you. All right, so I'm going to speak about the palliative approach to pain management in Parkinson's disease, but I think this can be applied to a whole variety of different neurologic conditions, chronic disease. It is geared primarily towards clinicians, but hopefully it will be interesting and of use to non-clinicians also. And I'm going to suppress my window of faces. So if anyone has something they need to say or questions, I'm probably not going to see it. So if any of the moderators want to interrupt, that's totally fine. All right. Say that again?
I'll keep an eye on things.
Okay, I appreciate it. All right, so I have no conflicts or conflicts of interest anyway. My objectives are to help providers, clinicians, and so forth feel more empowered to work with pain patients or people who are experiencing pain, to feel more comfortable comprehensively assessing pain in people with Parkinson's using a palliative care framework, to try and overcome and certainly identify any barriers in effective pain management, and then to provide pain management in a very targeted and systematic way, both with non and pharmacologic strategies. It's not all about pills all the time. So the overview of sort of the chapters of this talk will be first an introduction to pain and complex symptom management, followed by how to take a pain history and create shared goals, which is a bit different than how we're trained in typical medicine. And then thinking about how to manage mild pain, starting with non-pharmacologic interventions, followed by moderate pain with some pharmacologic interventions, and finally severe pain and introducing opioids potentially. So that's what I'm going to set out to do. So if the chief complaint is pain and a patient comes into the office or is seen in the hospital, how does that make you feel if you're a clinician? You know, someone's saying pain, that's the worst thing going on for me right now. That's what I need to help with. That's what I need you to help me fix. What's your initial reaction? Well, one is, where do I start? You know, we don't have enough time for this. I think on the clinic side, clinic visits are often so short and time goes by so quickly. And when you have Parkinson's, people are well aware that there are so many things to talk about. And the physician or clinician is often thinking, oh my gosh, how am I going to have time to manage the pain on top of everything else? They might be thinking, who can I refer them to? You know, who's a pain specialist that can help us here? Can we get by with Tylenol and diclofenac gel, also called Voltaren gel? Or how about tramadol? You know, a lot of people mistakenly think that tramadol is sort of a safe opioid. It's like an NSAID, a non-steroidal, but a little more powerful, mistakenly thinking that. So what's your initial reaction if you're a provider and somebody comes to you complaining of pain? Could be any of these things. So let's start with the introduction to complex symptom management, particularly pain. So when we think about pain management, right, we are often met with all sorts of stories about the opioid epidemic. Back in the 90s, when I was in Rochester, actually, the pharmaceutical companies were trying to convince the medical profession that opioids were not addictive, and therefore they were prescribed more and more and more and more. And then we wound up having what's called an opioid epidemic with some irresponsible prescribing, lots of addiction, and all the byproducts of addiction. And you just see these numbers are staggering. The data in the middle our data from 2019 published in 2020, and you'll see 70,630 people died from drug overdose in 2019. Now add to that the pandemic, right? And the numbers are even worse. The opioid epidemic may have killed 90,000 people in 2020. Overdose deaths have surged during the pandemic. So this is not getting better, at least it hasn't in the last year from the addition of the pandemic. But like many things, swinging to one extreme, there's the risk that it could swing to the other extreme, right? And we don't want to overlook the potential for undertreated pain as another kind of epidemic, right? Where clinicians become skittish about prescribing opioids or aggressively managing pain for fear that we're going to make things worse or contribute to the opioid epidemic or be in some sort of legal mess as a result of it. So there's a lot of fear around appropriately managing pain and skittishness. So anything in extreme, we're trying to swing the pendulum back towards the middle and be responsible about managing pain. So in order to lay the groundwork for thinking about this in the context of palliative care, let's think about some basic goals within the palliative framework. The idea is that we'd like to think about all diagnostic and therapeutic plans made in terms of the person with the disease, not the disease first, right? And that involves a lot of exploration, which we'll get into, on how to best understand the person in the context of their disease, or in this case, in the context of their pain. We want to maximize patient quality of life and function, not necessarily longevity. We want to really hone in on quality of life and function when we're thinking about this from a palliative perspective. We're trying to minimize suffering of not just the patient, but also the family or whoever's close to them. And oftentimes that includes aggressive symptom management. And don't forget, palliative care, there's nothing high-tech about it. It's high touch, maybe you could say. But not high tech. It's pretty basic what we're setting out to do here. It's trying to understand the lived experience of somebody's time with pain in this case and make sense of it. So where do we start? The first place to start from a clinician standpoint is to believe the patient. Pain is whatever the patient says it is, right? I think so often in neurology in particular, we see a lot of overlay with psychiatric disease or functional neurologic or epileptic disorders. And sometimes it's easy to doubt what patients tell us and be skeptical. And while healthy skepticism makes sense, we have to start at a point where we are on the same page with the patient, hearing them and believing them. It's not to say that using this pain as whatever the patient says it is a justification to just overprescribe opioids. That's not what I'm saying, but this is a good starting point. This is a necessary starting point when we're dealing with pain patients or patients complaining of pain. And remember, pain is not just physical, right? Pain has potentially a multitude of effects. If you have yourself dealt with chronic pain, you understand this very well, or seen someone close to you suffer from chronic pain, you get it. Because pain is certainly physical, but it could be psychological. It could have a huge impact on someone's outlook on life. It could feed into depression, and that could be a vicious cycle. It could impact the social side of their life. And even existentially, spiritually, pain could certainly have a huge impact. So this concept of total pain, thinking about it as far more than just physical, came from Dame Cicely Saunders, who's really responsible for the modern hospice movement. She came from the UK, was responsible for really developing the hospice field from which palliative care was derived initially. And she was a wonderful nurse, social worker, physician, and writer. She did so many things and was a huge force, tour de force, really. So this concept of total pain comes from her. And because one person, a physician, a nurse, can't possibly have the skill set to address all of those different domains, an interdisciplinary team makes the most sense, and that's where palliative care comes in. Palliative care is best practiced with an interdisciplinary team, a team made up of a nurse, a chaplain or spiritual counselor, social work, clinicians, nurses, doctors, APPs, physician assistants, with the patient and family at the center of it all. And the idea here is that when we're thinking of total pain, we're coming at it from different directions and different areas of expertise. And all of the members of this interdisciplinary team are trying to come up with shared goals, treatment goals, and otherwise to help the patient and family, as opposed to a multidisciplinary clinic where different people from different disciplines are coming up with independent goals that aren't necessarily brought together into shared goals. So what are some barriers to effective pain management? I'm sure you can think of many, right? What gets in the way of providing good care and good pain management? Well, certainly an inadequate assessment, not sitting down and really understanding the nature of the pain, where it's coming from, the etiology, et cetera, provoking features. Patients can sometimes be reluctant to report their pain. I'm just finishing a stint in the inpatient side, and a lot of times we'll see cancer patients that don't want to tell you that they're in pain because they're afraid that that means their cancer is getting worse, and they'd rather sort of ignore it and not take that on. So a lot of times patients might be reluctant to report their pain. The encounter times, right, clinic visits are awfully short, and so that's certainly a common barrier to effective pain management. A lot of times patients are reluctant to take opioids for fear of addiction. A lot of clinicians just feel skittish for a lot of reasons, including lack of training in chronic pain management. And then of course, prescribers are reluctant to prescribe opioids for fear of contributing to this opioid epidemic. And then this perception that chronic pain patients are difficult. You know, sometimes, providers come in thinking, oh, this is going to be so complicated and it's intimidating, and they shy away from it. So these are all sorts of potential barriers to effective pain management. I'm sure there are many others. But the silver lining for all of this is that there's the potential for a stronger alliance with the patient. If you keep this patient in your clinic and manage or try to manage their pain with them, that might just strengthen the relationship you already have with that person who you're seeing chronically anyway for their Parkinson's disease, for example. This is often a huge source of impaired quality of life. And if you help address this, you're making a big impact potentially on their quality of life. Even if we can't cure their underlying disease, we have the potential to make a huge impact. Less cooks in the kitchen. If we're the ones, as say the neurology team, to continue managing their pain, we don't have to now bring in another consultant from a pain clinic or somewhere else to add to the cooks in the kitchen. So keeping the patient in your clinic simplifies things from that regard. And then it can help improve your own confidence in managing pain. The more you do it, the more practice, the better you feel about it, the better you get at it. So there's a lot of potential silver linings to taking on the pain management of our patients in neurology. So what about the exploration that's involved in taking a history and creating shared goals? Let's follow a patient now through the course of the rest of the talk. We'll call him JP. He's 57, right-handed guy. He's got newly diagnosed Parkinson's disease, and he presents with worsening left shoulder pain. It's a common presentation. He's got no history of trauma, no prior injury that we know of. And his medications are metformin, so presumably he has diabetes, and rasagiline, a mild medication for Parkinson's. It's an MAO-B inhibitor. It's often initially started when people were first diagnosed. He's been sober since age 25, and he's been married for 27 years. Remember, he's 57. So in coming up with a comprehensive pain assessment, I like the word exploration as the first word we think about. Okay, let's explore his pain, and let's do it in a systematic way. We want to understand the meaning of his pain, not just the details of it, and I'll explain that more in a minute. And we want to come up with goals of care. These are based on his values, not necessarily goals of treatment, but actually what he's hoping for as we work together and manage his pain. I'll make more sense of that in a moment too. And certainly we want to understand the characteristics of his pain and the mechanism. Why? Why does he have pain in the first place? So let's dive into it. Again, we've got to start from believing the patient. And pain is tricky, right? Because sometimes you'll see someone who looks perfectly comfortable, but they're telling you they have 9 out of 10 in severity pain. I mean, it's hard to reconcile that, but we've got to start with believing them. So we're going to take a careful history of the patient's complaint and place it temporally in the patient's history of neurologic disease in this case. We love mnemonics in medicine, and palliative medicine and neurology are no different. So one handy mnemonic that we often learn in medical school is the OPQRSTU mnemonic, which helps remind us about all of the elements we can ask about when we're trying to hear about someone's pain characteristics. When did it start? Onset. Palliation, provocation, meaning what makes it better or worse. The quality of the pain, what are some adjectives to describe it? What region or part of the body is it in? Does it radiate? How severe is it? What's the temporal pattern? Did it start recently and abruptly? Did it kind of creep in slowly and so forth? And then what useful therapies have been tried? We want to assess the functional impact. How is this affecting your function? We want to evaluate the patient's psychological state. Also not forgetting to take stock of whether or not they have a history of alcohol use or drug dependence already. And then we want to perform a careful medical and neurologic evaluation, a physical exam, critical. And so pain assessment scales come up from time to time, and people ask, is it useful to use these? Which ones exist? They may be useful. This is a way to try and quantify the characteristics of the pain. They might be useful to assess the efficacy of therapies. In other words, if they fill out the pain assessment scale on this day before they've had an intervention, and then you've provided your intervention, you can try and better quantify the improvement, hopefully, that was made. But the most common way to assess pain in a very quick way is the 0 to 10 scale, with 0 being no pain and 10 the worst pain imaginable. So a severity scale. The brief pain inventory is a handy, pretty straightforward scale that I'll show you in a moment. There's also the McGill pain questionnaire and some others. Another one we see often in the hospital is the visual analog scale. You see it here. It's pretty easy for someone to just point to the number or to the face that coincides with how they're feeling with respect to pain. I'll tell you, certainly a challenge in assessing pain severity is when dealing with somebody who has advanced dementia. In those cases, we rely less on the patient's reports, but more on a proxy if we have family around who can kind of interpret for us what they think the pain is like. And we're trying to read a lot of body language in somebody who's not able to communicate well or at all for themselves. So looking for a furrowed brow, clenched fists, other signs that they might be in pain but not able to tell us. So here's the brief pain inventory, the BPI, it's the short form. And briefly, I'll run through this as it pertains to our patient JP and his shoulder pain. So he highlights on the picture where the pain is. It's his left shoulder. The pain at its worst is a 7 out of 10 in severity. At its best, in the last 24 hours, it's a 2 out of 10. So from 2 to 7 is the range of his pain severity. On average, it's about a 3. So that's kind of mild. And right now it's also a 3. He's tried Advil, which has been minimally effective, 10% effective. And then on the right side, you see other elements that this pain has affected, right? His general activity is affected, 7 out of 10. Mood is affected, 6 out of 10, and so on. You'll see sleep, I've highlighted there with the red arrow, is 8 out of 10 affected. So overall, this is a total score, if you will, of 54. It's a rather high score, which is interesting because he's got a 3 out of 10 pain score, which is kind of mild, yet it's a pretty high score overall, which just means that it's making a big impact despite the fact that it's mild in severity. So let's hear more about our patient JP. His Parkinson's disease was diagnosed just 8 months ago, and he has slowness and stiffness, so he's not a tremor predominant PD patient. And let's go through our mnemonic, the OPQRSTU mnemonic. Onset of pain was 12 months ago, so it predated the diagnosis of Parkinson's. In this case, what makes it better or worse? Well, the pain in the shoulder is somewhat better with heat and rest, worse with shoulder abduction and external rotation. Those movements make it worse. The quality of this pain, dull, aching. It's located in the outer shoulder area and the upper arm. Severity, as we know, is about 3 out of 10 on average, and it's chronic. It's been going on now for a year. He's tried NSAIDs, non-steroidal anti-inflammatory drugs with some benefit, but it looked like it was about 10% helpful. So how's this affecting him functionally? Well, he's not skiing as much. He's not going to Bristol Mountain as much. He's slower at work. He's a salesman. He can't lie on his left side, on that side where the shoulder pain is, and that's resulting in less sleep. and he's not using any drugs or alcohol. And on examination, he's got restricted movement in that left shoulder. He's got pain with passive and active glenohumeral motion. And his ability to externally rotate that shoulder is less than 50% compared to the right side, his normal side. So that's where he's at with this pain. But now we want to make sense of this, really understand the lived experience of the pain for this gentleman. So understanding what the pain means to him and the psychological impact of this pain are critical components of the assessment. And I think all too often in medicine, we stop there where we just were. We've got all of the characteristics and severity numbers of his pain. And now what? Well, now we keep going. We keep exploring. So we ask questions like these, which might seem odd, but I think they are highly revealing. So we ask him, in what parts of your life do you most notice the pain? And he says, when I'm washing my hair in the shower, skiing, going to the gym, and being active. And now this next question, how do you make sense of this pain? It might sound like the oddest question ever, but here's what he says. The doctors say my Parkinson's is mild and I shouldn't worry about it, but this pain is a constant reminder to me that I now have a disease. I mean, that's huge, right? If we hadn't asked that question, we wouldn't realize what this pain actually signifies to him. Then we ask, how are you able to carry on with your day-to-day with this pain? And he says, well, I try to avoid movements that will bring on the pain naturally, but still, now we're knowing he's avoiding doing things, which certainly isn't going to help this shoulder issue. And then I've stolen this question from Bob Holloway. I love this question. What's the hardest part of this? And the answer, he says, having a frequent reminder that I have an incurable disease. So this pain, which for some people might not be a huge deal, it's 3 out of 10 in severity, it's a shoulder pain, represents a lot for him. And then we ask, with better pain control, how would your life look differently? He says, I would get back to being more active and try to temporarily forget about my new diagnosis of Parkinson's disease. Wow, we've learned a lot to add on top of the typical pain questions that we've already asked. So the next step is to classify his pain. We've now gotten a better history of his pain and so on, but we've got to understand what the cause is. We can't stop there. We can't stop here yet. So one very global way of characterizing pain is to think about it in time. Is it acute, where there's an event that happened and brought about the pain immediately? Is it something that's getting better over days to weeks? Acute pain is usually nociceptive, and I'll explain what that is in a minute. Or is this chronic pain, something that's lasting more than 3 months, say, like in this case? Often there's an unknown cause when it's chronic pain. It could be multifactorial. It often persists after an inciting event or an inciting cause has resolved. So something happens, but then the pain just continues on and on for an indeterminate amount of time. And this kind of chronic pain can either be nociceptive or neuropathic. These are the two main general pain types, which we'll get into. So remember the dictum in medicine, primum non nocere, right? First, do no harm. Nocere is from harm. So noce comes nociceptive, harm leads to pain. So nociceptive pain is where you have direct stimulation of nociceptors, which are pain receptors that detect mechanical, chemical, thermal stimuli. When you feel something that hurts, those are the receptors responding. Whereas neuropathic pain is more of a nervy pain. It's where there's a primary lesion or dysfunction of the nervous system. So nociceptive pain is direct stimulation of a normally functioning or intact nociceptor, pain receptor. And there's transmission along normal nerves, right, in standard nociceptive pain. It can be somatic or visceral. Somatic means something that innervates the skin, the bone, the muscle. It's usually a precise innervation. It can be sharp, aching, throbbing. Whereas visceral is often related to the autonomic nervous system, internal structures in the belly, the GI tract. That's more of a visceral type of nociceptive pain. It might be difficult to really pinpoint. Sometimes if someone has an appendicitis, it's not exactly where the appendix is. It can be crampy pain. So nociceptive pain can be somatic or visceral. And the way we typically manage nociceptive pain that's relatively straightforward is with NSAIDs, non-steroidal anti-inflammatory drugs, opioids, or adjuvants. And I'll tell you what that is in a moment. So very briefly, nociceptive pain, you see those yellow triangles, those are the stimuli, whether it's a mechanical, a thermal, a chemical insult that then that gets the nociceptor to respond, and the signal travels up these C fibers, which are myelinated or unmyelinated, either one, and they get to this Lissauer's tract, get to the part of the spinal cord and the dorsal column, and then second order neurons progress upwards towards the brain, to the spinal thalamic tract, and get all the way up usually to the cortex, part of the brain where the sensory cortex is. And this happens very fast when you experience some sort of external stimulus that causes pain. And then there's a descending pathway that's often the modulation of that pain and how that pain is interpreted and felt. So just a very cursory, rough projection of how nociceptive pain works. And now let's bring it back and make more sense of it, bring it back to our patient. So remember, he's got this shoulder issue. It started a year ago, a bit in advance of his Parkinson's diagnosis. And we've diagnosed him with adhesive capsulitis. That just means frozen shoulder. This is a common initial presentation of someone with Parkinson's, often because they're not swinging that arm. It's a ball and socket joint. It needs to swing. And as the PD is setting in, they're swinging it less, giving it less rotation, and it's becoming inflamed. So this is a nociceptive, somatic, or musculoskeletal type of pain. You'll see in the diagram, the smooth tissues of the shoulder capsule become thick, stiff, and inflamed. You'll see a normal one on the left and an affected frozen shoulder on the right, that inflamed joint capsule. And certainly this can happen outside of Parkinson's disease for sure, but it's also a common early on presentation in PD. So musculoskeletal conditions are seen in as high as 70% of Parkinson's patients, and it's the most common cause of long-term pain and physical disability. We often forget to think about pain in the context of Parkinson's, and absolutely PD can cause pain in a variety of forms, which we'll see some other forms in a moment. And then frozen shoulder occurs in up to 45% of people with Parkinson's disease, so not uncommon. So communication about pain management. So next steps, as we think about, we've identified what the cause is. We understand a much more global sense of his pain, how it's affecting him. Now, how are we going to transition or segue into management? We want to explore what's most important. And for some patients, distinguishing between helping function and helping pain sometimes are separate. Sometimes they go hand in hand. In other words, there may be patients, particularly say in a hospital setting, who are having severe pain, who want us to control the pain no matter what. Even if it sedates them and they become groggy, that's okay with them. They're going to compromise function for good pain control. In an outpatient setting, that's perhaps less of an issue, but we still want to understand the expectations on what the patient's hoping for with respect to function and pain control. We want to describe to them the role of pain medications if we're starting medications, and we want to discuss expectations. What's the best we can expect from this treatment plan, and make sure that their expectations are in line with what's really possible. So we want to discuss the likelihood that we're going to completely eliminate their pain. That may not happen, but we may take it down a few notches. We want to discuss the likelihood of pain being chronic, and discuss best, worst case scenarios and most likely scenarios, right? What's the best we're going to do if everything works the way we want it to? What's the worst case scenario, and what do I think as a medical provider is going to be the outcome here with this plan, this treatment plan? We want to create shared goals and discuss what success looks like. So for example, for some patients, taking their pain from an 8 to a 5 would be reasonable, and they would be okay with that. So, obviously we all want pain to be a 0, but if we can get it to a 5, that would be a success. We want to discuss that we're managing and not fixing. So we may not be able to fix the underlying cause, but we're going to manage the heck out of it and see what kind of relief we can help bring about. And then check in, what's most important for you in your life. So as I said before, a patient who wants pain controlled regardless of side effects, particularly someone in the hospital who's okay with being drowsy as long as their pain is controlled, would be a different approach than someone who wants to maximize wakeful productivity and function, right? So we're constantly trying to weigh side effects and benefits as we discuss this with the patient. So now what? We have a very comprehensive assessment of the pain, its meaning, its impact, and what this patient is hoping for. So where do we go from here? Well, some of the intangibles and other things to add or sprinkle in to pain management could include the 4 A's. From the perspective of a clinician, we want to remember that a pain management strategy is going to be even more successful if we have a good working relationship with the patient, right? So we want to make sure that we feel a connection and they feel a connection to us, that they feel listened to, heard, cared for. We want to make sure that the treatment strategy is affordable and not prohibitively pricey. We want to make sure that they're able to follow through with the plan we're laying out and that what we are laying out for them is available. So for prescribing physical therapy, we want to make sure they don't live in a rural area where PT isn't an option. So the 4 A's can be additionally helpful when we're fine-tuning our treatment plan. We want to make sure there's continuity of care to ensure compliance and reduce anxiety. So we're not just going to start a pain management plan and say, good luck with that. You know, we want to have them checking in regularly and coming back for visits, however we want to do it, but we don't want to abandon them, certainly. And we want to reassess their response with a short follow-up potentially and during an appropriate interval. So now let's get into some of the details of the management itself. So in this case, we're talking about mild pain. Remember, it's about a 3 out of 10, but with a big impact on his life. We'll think first about non-pharmacologic interventions. I'm sure you can think of many, right? Just think for a moment about all the potential non-pharmacologic strategies when it comes to trying to address pain management. So naturally, we want to treat anything that's reversible and fix anything that is fixable. We want to think about temperature or, applying heat or cold to the affected area, just basic things. Elevation of a swollen extremity might be helpful. And then all sorts of other complementary potential therapies, right? Music, aromatherapy, distraction, pet therapy, journaling, acupuncture, mindfulness techniques, guided imagery, biofeedback. All of these things have their place, and for some people can be really helpful or at least a wonderful adjunct to another additional pain management strategies. Physical therapy, we love that, particularly in Parkinson's disease and other movement disorders. Therapeutic massage, hypnotherapy, a TENS unit. So what can decrease the perception of pain but increase mobility and function that isn't medication? Well, mindfulness-based interventions like MBSR, mindfulness-based stress reduction, actually can be helpful, as well as cognitive behavioral therapy, CBT. Hypnosis has some benefits potentially in decreasing the perception of pain. I mean, think about it, it makes sense, right? If we are only focused on the pain and that's all that's on our mind, it's going to feel worse potentially than if we're able to shift away from it even for a little while. So MBSR, in a study looking at MBSR versus CBT versus usual care in back pain, it was found that there was clinically meaningful functional improvement in those who received MBSR and CBT at 26 weeks compared to those who didn't receive it and just received usual care. And then at 52 weeks, improvements continued in the MBSR group. So important to not overlook the potential benefits in pain management or even other symptom management from modalities like these. So if we do get to a point where we want to think about medication, pharmacotherapy for pain, you may have seen this WHO ladder. It's been around since the 80s. And even though it was developed for malignant or cancer-related pain, it can be extrapolated and a good starting point for other kinds of pain. And it doesn't have to be stepwise. If someone has severe pain, you don't have to start with Tylenol if that's just not appropriate and make your way up the ladder. You hone right in on the level of pain where this person is at. So in the case of our patient right now, he's in the mild category. So that could include medications like Tylenol, nonsteroidals, or adjuvants. I've mentioned adjuvants before. These are medications that are co-administered to manage other types of pain strategies. In other words, if we're treating with Advil, but there's a neuropathic component to the pain, we feel like there's some nerve pain too, we might add a special adjuvant medication to help address the nerve pain portion of the pain. So it might enhance the pain management. That's what an adjuvant is. So in this case, we're at step 1 with this patient, and our options are listed there. So the way we managed this frozen shoulder for JP was we enrolled him in physical therapy. We scheduled the nonsteroidal anti-inflammatory to have it a certain time every day, certain times throughout the day, not indefinitely, but certainly for a few weeks or while he was in PT. And we used diclofenac or Voltaren gel, which is like a nonsteroidal anti-inflammatory that's topical to go right over the joint in his case. So 3 months later, his pain improved. He was not skiing, but began snowshoeing, and his sleep improved. Now he could lean on that left side and get some better sleep. So it did make a very meaningful impact for him. What about moderate pain? We're going to step it up now and thinking about how to manage that. Well, let's move forward in time with the same patient, JP. He's now 63. He reports left greater than right foot pain, worsening over several years. He says, it feels like I'm walking on broken glass when on the hard floor, or on a wire brush when I'm walking on a carpet. It can be burning or tingling. He actually wears special slippers that are a size too big, and he puts in multiple inserts. Some of them he made himself out of carpet padding. This is partially from a real patient. And that was his strategy to try and buffer the sensation in his feet when he walked. So he's tried Tylenol, ibuprofen, and gabapentin, 900 milligrams per day. Also of note, his hemoglobin A1C, which is a measure of the average glucose in his blood over the last 3 months, is 10%. That's highly elevated, meaning that his sugar, his glucose, has not been well controlled. Let's not forget, before we go down the diabetes pathway and thinking about his sugar and its effect on this presentation, that Parkinson's patients on long-term levodopa, carbidopa-levodopa, Rytary, Sinemet, at least 38%, up to 55% of them on long-term levodopa develop peripheral neuropathy. And the duration of exposure to the levodopa predisposes to peripheral neuropathy with a dose-dependent effect. The longer and the higher dose, the more likely to over time develop some degree of neuropathy. So let's not forget that and not necessarily blame all of this on the diabetes. So our BPI short form again highlights that he's got foot pain. It's a 9 out of 10 at its worst, a 7 at its best, and on average an 8. And right now it's a 9 when he's presenting to us. As you know, he's tried gabapentin or Neurontin. It's been 20% effective. And this has all sorts of impact. It's an 8 out of 10 impact on his general activity and on his mood, walking ability, and so forth. 8s and 7s out of 10 for the impact this is having on different elements of his life, like relating to other people, sleep, et cetera, et cetera. So this is an 85 total score. This is worse than when he presented to us with his frozen shoulder a few years ago. So we're going to ask him those questions about how he's making sense of this pain now. In what parts of your life do you most notice the pain? He says all the time, when I'm walking, when I'm resting, doesn't matter. How do you make sense of this pain? He said, I am constantly living with this. It's like a form of grief. How are you able to carry on with your day with this pain? He says it makes me tired and hopeless. So it's impacting him psychologically, not surprisingly. And my favorite question, what's the hardest part of this? He says, I'm not able to be active and I'm afraid it will only get worse. It makes me feel hopeless. And then we ask, with better pain control, how would your life look differently? He says, I want to get back to taking walks around the neighborhood with my wife. That is one of the things he's hoping for. That is a goal of care, a value-based goal of care. So we want to use that as our target, trying to help him take walks again with his wife. So when it comes to neuropathic pain, we already discussed nociceptive. Now we're going to talk briefly about neuropathic or nervy kind of pain. it may be well beyond any observable injury, right? You may not see anything that looks abnormal when you look at the skin where they're pointing out the pain. It's usually got a burning, tingling, shooting, stabbing, electrical character to it. Any of those adjectives are most commonly neuropathic related. And the management of nerve pain, neuropathic pain, is commonly with TCAs, tricyclic antidepressants. These are old-time antidepressants like nortriptyline or amitriptyline, SNRIs, serotonin norepinephrine reuptake inhibitors like venlafaxine, Effexor, or duloxetine, Cymbalta. Calcium channel alpha-2 delta ligands, gabapentin, which he's on, and pregabalin, which is also Lyrica. We can also consider opioids for neuropathic pain and certainly adjuvants. So there are a lot of different causes for neuropathic pain. I've already mentioned diabetes, and poorly controlled blood sugar is one. Chronic or long-term use of levodopa could contribute to this. Various infections, neurotoxins, alcohol, chemotherapy, a whole host of different causes of potential neuropathic pain or neuropathic syndrome. What's hard about this in particular is that there can be multiple reasons for their neuropathic pain contributing together, and the manifestation in people is so variable, just like Parkinson's is so variable in people. And that can really make it harder to treat, and it's a lot of trial and error when it comes to management. So what is the American Diabetes Association telling us about the management of diabetic neuropathy? They're recommending from 2017 to consider either pregabalin, which is Lyrica, or duloxetine, which is Cymbalta, as the initial approach. Our patient isn't on either of those things. He is on gabapentin, and they say it may also be used as an effective initial approach. Although not approved by the FDA, the TCAs, those old-time antidepressants, may also be effective, but we need to use them with caution because they're kind of dirty drugs. They have a lot of potential side effects, including cognitive slowing. So given the high risks of addiction and other complications, the use of opioids, including tapentadol, which is Nucynta, or tramadol, or Ultram, is not recommended as first or even second line therapy for treating pain due to polyneuropathy. And I'll just call out tapentadol or Nucynta and tramadol are often misperceived as weak opioids, meaning that they're safer in some ways in terms of addiction and side effects than the other opioids. And that's just not true. They are opioids. And so I think it's important for providers to remember that. So what's our AAN, Academy of Neurology, telling us? Kind of an old statement from 2011, but nonetheless, they had level A data, so the strongest data, at least two good controlled studies showing that pregabalin or Lyrica is most effective at 300 to 600 milligrams a day, followed by level B data for gabapentin, valproic acid or Depakote, venlafaxine, duloxetine, amitriptyline, et cetera. So you see there the list of level B possibilities. Not recommended, there's a list of medications there as well. And then a bit more recently than that, in 2015, Lancet Neurology had a nice review of the use of medications for neuropathic pain in adults, finding that pregabalin or Lyrica has a linear pharmacokinetic profile, meaning it's more predictable in how it's going to help compared to gabapentin. Excuse me. Nonetheless, you can see the dosage ranges there that they included in this meta-analysis, or in this review rather. So several options when it comes to different medications to treat neuropathic pain with slightly different mechanisms. So in his case, we replaced the gabapentin with Lyrica, pregabalin, and titrated up to about 400 milligrams per day. We then started duloxetine, Cymbalta, and got that up to 60 milligrams a day. And I'll just say that despite the fact that combination therapy using more than one agent is widely used in clinical practice with pretty good results, the guidelines don't really contain a whole lot of information or recommendations for how to manage neuropathic pain with multiple agents at the same time. We also, again, enrolled him in physical therapy. He also got some counseling, which was helpful. And mission accomplished, he was able to walk again with his wife, which was his hope, his goal. His pain was improved to a 4 to 5, which he said was tolerable. He's walking 1 to 2 times a week. He feels less hopeless. He continues in counseling. And for the last section, in the last little bit of time we have, I'm going to talk about severe pain management and opioids. There's a lot we could say. That could be its own topic for sure. So I'm going to try and make it relevant in the context of this talk here. So JP, who we've seen at 2 different time points, is now at a 3rd time point. He's now 67 years old. He's got worsening low back pain, severity 8 out of 10. He does have lumbar stenosis, but he's deferred surgery. He's been doing PT, so we can't add that because he's already in it. He's received some epidural steroid injections with diminishing benefits. And as a result, his depression is getting worse. He's got low energy, impaired sleep, and now he's got marital strife too. Hard to know the role that's playing or if it's the result of him having a harder time, but nonetheless, that's part of the picture. So his goals are to attend the weekly soccer games of his grandson, to engage more in physical therapy, put forward some more effort there, and to avoid surgery. So here's our WHO ladder, once again, with respect to severity of pain. And currently, this puts us in the severe category for him, 8 out of 10, so right at the top. And now we're going to talk about opioids. So opioids, or narcotics, or opiates, have a lot of charge around them, right? We've already talked about the opioid epidemic in the US and all that goes with that. So there's a lot of skittishness when it comes to opioids. But we still need to consider them in certain cases because sometimes that's the only answer to manage somebody's severe or refractory pain. And we're always trying to make sure that the potential benefits far outweigh the potential risks and side effects. The potential side effects, though, are several, particularly nausea, sedation. Both of these things generally improve after a few days of being on the opioid and arriving at a steady state. Constipation is huge, and when you have Parkinson's, it's already usually present, so it could certainly exacerbate constipation. 40 to 90% of people with chronic opioid use develop constipation. Encephalopathy, which is altered mental status, can also be a side effect in some cases of opioid use. Myoclonus, jerking movements, can occur in certain instances with opioid use. Urinary retention, not something we want to cause, could also be a potential side effect. And then respiratory depression, it can slow down drive to breathe. So we certainly want to be cautious for a variety of reasons. So do's and don'ts about prescribing opioids in the case of treating severe pain. We want to always start with immediate release opioids as opposed to those long-acting, slow release opioids, and try and get a sense of what their needs are by using the short-acting forms of the opioids. As always, especially in Parkinson's, we start low and go slow when it comes to making adjustments to medications. When we need it for acute pain, we're going to prescribe just what we think the patient needs. We're not going to overdo the number of pills we're prescribing, and we're not going to just endlessly refill this. It's acute pain. It's hopefully going to get better with other interventions. So we're not going to sign someone up for chronic opioid use. The goal is to have it be temporary and get them through this rough patch. We're not going to prescribe extended release or long acting for acute pain, again, with the expectation that the acute pain will get better once the offending problem resolves. So we're reserving long acting opioids for chronic pain. We'll reassess in short order, less than a month, and see how they're doing with the opioids. We also would love to add onto opioids non-opioid analgesics. It can be helpful to schedule, like we did in the past, Advil, for example, or Tylenol for a short period of time to kind of have a baseline of another mechanism of pain management while we're also trying the opioid, and it might reduce the opioid requirements if we can use more than one agent. There is a high risk for respiratory depression, as I mentioned, particularly in the elderly, in those with known lung disease when they're also given with benzodiazepines or sedatives like Valium. And if oral and IV opioids are given too close together in a hospital setting, all of these can potentially lead to respiratory depression. Remember that opioids follow first order kinetics, which means there's a certain predictability to how they work. So the peak concentration in the plasma, or the Cmax, varies depending on how you're getting your pain medication. If it's IV, it's 6 minutes. So within 6 to 10 minutes, you reach the peak. You'll see that top graph there. That IV, excuse me, opioid reaches its Cmax, its top plasma concentration, very quickly. If it's subcutaneous or intramuscular, it's a little slower at 30 minutes. And if it's a pill or oral opioid, it takes 60 to even 90 minutes for it to reach its peak plasma concentration in the system. So it's important to know that, to set expectations and to think about how often we're going to be dosing these medications, because we also have to think about the half-life. The half-life depends on renal clearance, how well the kidney's working, but in general, the half-life for opioids is 3 to 4 hours. And we would not want to dose an opioid any sooner than the half-life. So a frequency of no sooner than every 4 hours is what we're talking about. And in order to arrive at a steady state where there's more or less a steady level of the opioid in the person's system, we have to give it 5 half-lives. And with each half-life being about 4 hours, that's 20 hours. So practically speaking, what that means is we should not make any changes to their regimen any sooner than 24 hours later, because we don't know over time what that steady state's going to look like. So these are important considerations when we're prescribing opioids, both outpatient and in the hospital. So there have been validated measures developed to screen patients for the potential for addiction. I'll tell you about the opioid risk tool. It's pretty straightforward, just 5 items. The clinician completes it, and then it gives you a score that can kind of categorize the potential risk for addiction in that individual. The other important thing for us as providers is to review the prescription drug monitoring program. The state, excuse me, maintains when people are prescribed opioids, by whom, how many were dispensed, what pharmacy they got it for. That's really important and easy to monitor to make sure people aren't getting opioids from multiple sources, for example. The opioid risk tool is shown here. You'll see that the scoring differs for females and males, and it's looking at family history of substance abuse, personal history of substance abuse, age, whether or not there was sexual abuse, and any psychological comorbidities, particularly depression, and a few other things. So in this gentleman's case, he scored a 10, which puts him at a high risk for opioid addiction. So that's important for us to know going into this, so we know how better to monitor him. So in his case, we started him on a combination of Tylenol with oxycodone, and we dosed it at every 4 hours as needed, not any sooner than that, for his moderate to severe pain. Because of his high risk potential, we closely monitored him with a pain contract, weekly and then biweekly clinic visits. We gave him just enough tablets in the prescription to get him until the next visit. We did urine screens here and there. We observed his behavior in clinic just to make sure there were no red flags there. And we reviewed his PDMP with him and said, okay, looks like you picked up your drug on this date, so that he knows that we're staying on top of it. We also, whenever we prescribe an opioid, want to make sure that we are managing constipation. They go hand in hand. So in his case, after several months, no signs of abuse. He had adequate pain control with that regimen. He was taking about 2 of them a day with an average pain score of 4. He would pre-medicate before going to physical therapy and resumed walking in his neighborhood. If he had required more than 2 doses on a routine basis, I would have increased potentially. His fatigue was mildly improved. His depression reasonably well controlled. He was attending an adult day program and going to those soccer games twice a month. So in summary, I know that's a lot of information, but remember we walked through mild, moderate, and severe pain management, looking at it through the lens of someone with Parkinson's disease and some of the more common pain complaints, and try to apply a more palliative approach to the assessment and management of it. It's important to just be aware of potential barriers to pain control, because there are many. It's an opportunity to form a strong alliance with the patient, to clarify goals and expectations, to come up with a comprehensive assessment of the pain, and to really try and characterize the pain prior to the visit. And then assessing total pain, really trying to understand the lived experience of this person grappling with pain, what it means to them, what features are associated with the pain, and identifying the mechanism as best you can to really hone in and target what kind of treatment you want to provide. So again, this total pain concept, I think, is best attended to by different disciplines that are working together: spiritual care, social work, nursing, because everyone brings to the table their own expertise that can help the different domains of this person's suffering. Always want to consider non-pharmacologic therapies first. Consider using the WHO analgesic ladder as a starting point. Make sure if you're using opioids, you're assessing for possible abuse potential and monitoring as appropriately as you can. And for complex pain management, coping, and future planning, any of those are good reasons to consult a palliative care specialist. Just a little plug, I did with one of my mentees a neurobite through the AAN, which can be found on YouTube, on understanding the experience of pain and neuropalliative approach. Like 5-minute distilled version of what I just went through with you.